Doctor series is our signature series that we allow the community and other physicians and anyone who wants to ask questions of Black physicians. We know that you want to ask questions of people that look like you and have had the same experiences as you. And so it's something that we really enjoy doing. We enjoy reaching out to the community, being able to answer your questions. So please feel free to reach out to us by chat, and we'll be glad to answer your questions. We are going live. We're also going to be on Facebook Live. And if I figure out how to do it, I'm going to go Facebook Live. But we really welcome all of you for being here, and didn't really know we were going to be here at this point again with COVID-19. We thought that by this time we might be a lot further along than we are, but unfortunately we are not. We have done several episodes of Ask a Black Doctor based on COVID-19, and so we're going to have to revisit some of those questions from a long time ago, but also talk about some new issues and some new ideas that we have not yet discussed. And we know that things have changed a lot. Before we get started, I do want to just mention that we sent out to most of you a survey on wearing masks and your knowledge of COVID. Please, please, please respond to this and share it with your friends, especially your children or your children's children. I mean, we want young and old to please fill us out. We're trying to just get an idea of where we are as a community with wearing masks and our understanding of COVID. And then we'll be sending out a subsequent survey in the coming weeks to talk about some other things related to COVID. But please, please fill this out. Send it to your classmates, your fraternity brothers and sorority sisters, Jack and Jill, Links, Mocha Docs, everybody. We want to please get in as much data as we can. Do have to brag a little bit on the Atlanta Medical Association. We are part of the larger National Medical Association, which actually our convention was supposed to be here in 2 weeks, but we have to go remote. But we were looking forward to welcoming everyone to ATL. But we are proud to announce that we won the large chapter of the year, which is really a big deal in the National Medical Association. In fact, this is our second time in 3 years winning it. And so people are sick of Atlanta right now, but we're very excited about what we're doing. And what we're gonna do now, we're gonna jump right in, and we are gonna have some questions. We want you all to ask questions, but we also wanna just kind of have a conversation. Now we're going to have our panelists kind of introduce themselves, and I'll call on them. And please just tell us a little bit about you and what you're doing right now and how you're on this front line and battling COVID. And as they're doing that, if you see me looking down, I'm trying to get us on Facebook Live. So why don't we start with you, Dr. Bullock?
You're muted.
Hi, I'm Dr. Lenora Bullock. I'm an emergency medicine physician. I'm from Macomb, Mississippi originally. I went to medical school at Meharry Medical School, and I trained here at Emory, and I'm working with Wellstar Douglas and Wellstar Cobb in the emergency room.
Okay. Dr. Drayton?
Good evening. Again, I'm Joyce Drayton. I'm an infectious disease physician here in Atlanta in private practice, born in New York, graduated from Howard University, and I trained at Henry Ford Hospital in Detroit and did my infectious disease fellowship at Jackson, Mount Sinai, and the VA in Miami. Came to Atlanta and spent 8 wonderful years as a professor at Morehouse. Had a little foray as a medical director in managed care medicine, and have been in private practice for quite a while.
All right, Dr. Flenaw.
Yeah, my name is Eric Flenaw. I did my medical school training at the University of Texas Health Science Center in Houston. Went there through medical school, residency, fellowship, and was on the faculty for a little while. Then I transitioned to Atlanta, where I've been on the faculty at Morehouse School of Medicine for about the past 20 years. I am the chief of pulmonary critical care for Morehouse School of Medicine, and I work in the intensive care units at Grady Hospital.
And Dr. Flenaw, didn't I see you on a little magazine or something? Did you win a little award or something like that?
Yeah, when all this crisis started, there was some recognition given. We put together our COVID response team for Grady Hospital and worked with the city, and somehow word got out and I got a recognition for being one of the doctors at was one of the top doctors or something. So I appreciate it. Thanks for
Can you
calling
say
me
that
out.
a little bit louder, please?
Yes, I was nominated and received one of the top doctor heroes during this COVID crisis. So I very much appreciate the community that we serve for appreciating what I do.
And he was on the front cover. I wish I had a copy. If I had thought about it, I would have brought a copy of the cover. He's on the cover. So we really want to applaud you for your efforts. I mean, you've been doing it all along. So congratulations on that.
Thank you.
Dr. Adegwime, new to our Atlanta Medical Association.
Yes, and I am no celebrity. Not on the magazine covers. I'm Adeza Adegwime. I currently work as a hospitalist. I'm primarily at Emory Midtown Hospital. I work for Kaiser. I'm from Jacksonville, Florida. I did all of my training, med school, and residency at Emory, and I've been here ever since.
Okay. And last but certainly not least, Dr. Waziruddin. Dr. Waz.
Hey, yeah, Dr. Waz. Hey, thank you for the opportunity. Currently, born and raised in Atlanta, right at Grady Hospital, and matriculated to Auburn University and Morehouse School of Medicine. Did my emergency medicine training up in Detroit, and I've been back in emergency medicine here in Atlanta for the last 11 years at Atlanta Medical Center, as well as Cleveland Avenue, as well as downtown. Currently as the vice chair of the emergency department, as well as medical director of the Atlanta Medical South. And definitely happy to be here.
And Dr. Waz was one of our former students. Several of us taught him a few years ago. So we are very proud of you and the things that you were doing. Again, my name is Dr. Jones. I'm president, proud to serve as president of the Atlanta Medical Association, also known as ATL Med. I am a general surgeon by training, critical care, trauma surgeon. But my role here tonight is as the president of Atlanta Medical Association. We're going to jump right in. As I said, we have a cross-section of people here. So we're going to start out with some of the easier concepts and talks, questions, and then we'll get a little bit deeper. But Dr. Drayton, why don't you start us off by just telling us what coronavirus is and what's the difference between that and the flu? And in general, the difference between a virus and a bacteria.
Okay. Well, this particular permutation of coronavirus is like other coronaviruses. It's an RNA virus. It's a new coronavirus that I guess made its appearance in this country very early this year, although there's some suspicion that it may have been circulating last fall. It's different from the flu is because it's a different species of virus. And typically coronaviruses don't change their appearance and their antigens as frequently as does flu. We have yet to find that out. And the reason I mention that is because we do have a vaccine for flu, but remember every year the vaccine has to be redeveloped based upon which strain was circulating the year before. So coronaviruses other than this coronavirus are very common causes of common cold symptoms. But this particular coronavirus is very similar to one that emerged back in 2003 and 2004, which we called SARS, okay? And that virus caused very, very severe pneumonia of the lung. It was had a high fatality rate. Fortunately, it was very localized and it kind of came up and went down, and there really have been no documented cases of that particular virus since 2004. I forgot the last part of your question.
Yeah. And the difference between a virus and a bacteria.
Okay, well, bacteria are technically what you might call a higher form of life. You know that bacteria live in our gut. Bacteria can, contaminate the, bathroom and other places, but they do live independently. They can cause infection, but they replicate on their own, on the basis of their own genetic material. Viruses are considered a slightly lower form of life only because they cannot just replicate without kind of using the genetic material of the host. So an example would be HIV, which infects people, gets into your lymphocyte, and then uses your DNA to replicate itself. So those are kind of big you know, distinct microbiologic differences between viruses and bacteria.
And can you use antibiotics on a virus?
No, by definition, antibiotics are medications that fight bacteria. There are some antivirals, but an antibiotic like penicillin doesn't do anything against viruses.
What about Clorox? Can you use that on a virus?
Well, there are.
We'll get it. We'll get into that later. We're gonna get political in a little bit. Can you inject Clorox? That's, Dr. Bullock, you are on the front line working in the emergency room. Tell us what are the patients looking like when they come in the emergency room? What kind of signs and symptoms are they telling you about, and what are they looking like when they come in the emergency room?
In the emergency room, we're seeing all ranges of patients, from just people who have just a cough and a cold to people who are asymptomatic but feel that someone else in the household has had it. And then we have people who look sick as though they have the flu. And then we have the people that are very, very short of breath that need hospitalization. And then we have those patients who actually need ventilator support, meaning a respiratory support to help with their respirations. Their lungs are failing at the time from COVID. So the range is as simple as I can't smell, I'm short of breath, I have flu-like symptoms, I have nausea, vomiting, and diarrhea are also symptoms to I can't really breathe. And that's when it really gets serious, when we're getting into the I can't breathe.
And you use the term asymptomatic. What does that mean? We throw that term around a lot, but explain to folks, what does that mean, asymptomatic? Because that's important.
Asymptomatic means that you have absolutely no signs and symptoms. You're just walking around like a normal day. If we didn't swab your nose, you would not know you had COVID. So that's asymptomatic. And a lot of patients are walking around asymptomatic. But the problem with being asymptomatic is you absolutely do not know that you have the virus, but you can still spread this virus to your loved ones and friends and coworkers.
Dr. Waz, you're also in the emergency room. Doc, what are you seeing in your emergency room?
Yeah, sorry, I got disconnected. I think that like many others, clearly, we're seeing that. And, initially when we started, we did see a high incidence of patients coming from a nursing home and older patients in the first onset. But currently, we're seeing a lot more younger patients or people who've kind of been around their family members. I guess Dr. Bullock said asymptomatic, with minor symptoms, unfortunately, still our older population and those with comorbid conditions still at risk. So pretty much on the same lines, being in the South Fulton and downtown area, in the population, African-American and low-income population who are really at risk for multiple reasons. So we're seeing those asymptomatic patients. But again, now it's more folks who are on the, I say, not as elderly as we first saw in the beginning.
Now that seems like a complete shift, because before we were hearing, oh, well, young people can't get this disease, or we were hearing that Black people can't get this disease. So is that not true? Are we seeing Black folks getting sick from this disease?
Black folks didn't travel to Italy that much.
Yeah.
China. But no, on a serious note, I think that all like-minded individuals on this panel can agree that it's very serious, and I want people to really, just because of multiple factorial, besides just having COVID or access to care, access to proper testing or contact tracing, also economic pressures put us in different categories that we may transmit COVID to a loved one and or continue to operate or to continue to spread it without knowing. So again, African Americans do get it, from all ranges. And so I think that this is not a hoax, and this is a real disease, and we definitely are in unprecedented times. But, this is why we're here. We're here to kind of get things started.
Dr. Edegweme, just talk a little bit more about what Dr. Waz was saying. Why are Blacks getting it now? Why are we being ravaged by this disease more than others, Blacks and Hispanics?
That is a very layered answer. I'm gonna try without being too political or too long-winded to get to it. So I think we have multiple risk factors. I think there are many social determinants of health. So those are things such as access to care, things such as just not being believed when we go to the ER. So patients are going to the ER and perhaps are being turned away multiple times and then end up coming back much sicker. There are things such as us living in multi-generational households. So what I'm seeing a lot of this wave in particular is patients who may be a little bit older, who may have a grandchild or someone who lives in the house who may be in their 20s, who goes in and out. And so the patient themselves may be isolating, but the grandchild may not, and they're bringing it into the household. And then therefore the grandparent ends up in the hospital. I'm seeing a lot of that. Living in close quarters, again, multi-generational households. There are a litany of reasons, I think, why we are highly susceptible, some of which are social determinants, some of which are more so related directly to the healthcare system itself. And then in terms of just us getting sicker, I don't know that there's a very clear understanding about that just yet. I think the natural inclination of the media has been to kind of sit solely on our the comorbidities that exist, but I think there's probably more to it that just hasn't been unveiled just yet. But it's multifactorial.
And Dr. Flynn, you're a pulmonologist. I mean, you're also an internal medicine doctor. And originally, we thought this was just a pulmonary disease. And so, talk to us a little bit about the pulmonary aspect of it, but also about how it's evolved. And now we're seeing so many other symptoms unrelated to pulmonary.
Well, as this disease has progressed, we've started to find out a lot more about the mechanism of injury that it causes, both from patients' cares, CAT scanning, how the disease behaves when people are sick or intubated, and even then from, unfortunately, autopsy studies. Initially, it was just thought to be an inflammatory infection of the lung. But as things have progressed and we start seeing more of it, there's another component which involves a very, very defined and prominent inflammatory mediator release. A lot of inflammatory mediators, histamines, and other, interleukins are released from the body in response to this virus. And those mediators actually cause damage to the lungs. So what we see is an injury in the lungs, which causes the small vessels, the capillaries, to leak some fluids, and that fluid leaks into the lung space and impairs your ability to get oxygen across and carbon dioxide out. Along with that, this immune response, this reaction, triggers your clotting system. So you'll get blood clots. Blood clots occur in the kidneys, they occur in the legs, they also occur smaller in the lungs. So, classically what we'd see is pulmonary, with clots in the lungs or larger pulmonary emboli, but now a lot of smaller vessels are getting clots, and that impairs blood flow and, again, gas exchange. So now you have leaky lungs that leak fluid, plus you have inflamed lungs, plus you have those which are also leaking fluid and just causing this overall inflammation. And that's what we're seeing in terms of the respiratory system. For the rest of the body, it's equally as pronounced. The kidneys are affected. And often the patients will come in when they reach the intensive care unit. Not only do they have respiratory failure and trouble breathing requiring a ventilator, but they may have another organ system go down, and usually secondary it's the kidneys. And so they require dialysis. And then after that, we see cardiac disease, heart failure, we see clots throughout the body, and we see what's a cardiovascular collapse, where they can no longer support their own blood pressure and cardiac function. And all of those presenting at one time brings in an extremely sick patient into the intensive care unit.
And we're going to get to that in just 1 second. This is kind of to everybody. Before, it seemed like it was a slower progression from the time you got sick until the time you might have to go to the ICU. But what we're hearing now is people coming into the hospital blue. And so I just want to, first from our ER docs, are you seeing that? I mean, are you seeing people walk in the door sick that really need to go to the ICU or be put on the ventilator right away? or is it getting a little bit better? What are you all seeing, first of all, in the ER?
Well, what I'm seeing is, formerly we were seeing people that would come in just short of breath to the point that they had oxygen levels that were not compatible with life, but they were talking to us but breathing very, having very difficulty with their breathing. And what we're seeing now is a lot of younger people coming in who are at that stage, between 25 and 55. I've noticed that a lot more. We still have the older population, but I'm seeing a lot more younger population come in now at that stage.
Yeah, and absolutely. I think that, we saw a myriad of people, and I think Dr. Bullock is the kind of trend is about the same. We see people initially, when they first started, people come in with oxygen levels very low. And in our normal practice, we will, put them on the ventilator, we do all these invasive things. And then as we found out had COVID developed, we started doing less invasive things because we figured, hey, let's do no harm by putting them on the ventilator. Right now, what we're seeing, people may come in with mild symptoms, but again, it's amazing how the body responds with low oxygen levels, and they're actually talking to you. And then we've seen people who kind of crash, because they stayed at home and kind of did the whole the social distancing and kind of did what we kind of prescribed, told them to do. So again, this is fascinating from a medical perspective because we've never seen anything like this. It's unfortunate, but we've learned so much about the human body and its response to this, the things that you can't see, such as COVID-19.
Okay. Dr. Adegweme, of the people that you're seeing, and you hear your colleagues talking about, that come into the hospital with COVID, are most of them leaving the hospital? Do most of them have to go to the ICU? Are most of them dying? At your particular hospital, I know you can't speak for everyone, but what are you seeing at, and you're at Emory Midtown?
Mm-hmm.
Okay.
I can only speak to my experience. So I would say the majority are leaving, but I would say a good number, and again, I don't have the exact stats on my particular facility, but I would say a decent chunk of them are going to the ICU. It's probably not 50%, but I would argue probably at least a quarter of them, if I had to ballpark it, which again, is very distinctive from the flu. I think that's a really important distinction to make is just in my practice, I haven't seen flu patients come in and go to the ICU in that number. I think there's something very different about this disease process.
And let's back up a little bit. Maybe we should have talked about this beforehand. Back to you, Dr. Drayton. How can we prevent from getting this disease in the first place? Are there any things that we can do as individuals to help decrease our risk for getting this disease or mitigating it once we get it?
Well, I mean, it's the same things that we've heard from the beginning, particularly since, the states are opening up, is you have to personally try to avoid crowds. You may have an opportunity to go to an event or even a church but you're going to have to know the lay of the land and have some sense of, how crowded it's going to be, and the like. Certainly wearing a mask. Fortunately, even if there's not a mandate, private businesses can insist. So for example, I know some CVSs will say, don't come in without a mask because it's my private business and I'm kind of trying to tell you to do that. And
tell us just a minute, because I know most people kind of understand why, but talk to us and explain in basic terms why it's useful for everyone to wear a mask.
Masking, I'm talking to lay people. I know that other folks will ask me about solid, scientific evidence, but just teleologically, if you have a mask covering your mouth and you're talking or sneezing or whatever, you're going to reduce the amount of, spray that leaves your body. So certainly if I'm wearing a stocking, it's a little bit different than wearing an N95. But in general, you know, it's going to help reduce the amount of respiratory secretions that you let out. You're much less likely to be kind of touching your face and doing other things that we've been told can reduce the risk of infection.
Okay. From what you all are seeing in your own circles, these are your social circles. Are most people wearing masks?
I'm not socializing, so
I see a mixture.
my husband and my dad.
I think it's maybe a little bit I guess biased in my direct social circle. Part of it is because I think a good number of people know what I do and where I've been working. So I see when I get around them, they'll immediately put their mask on, probably just out there, which is the right thing to do. But I'm seeing a lot more people starting to pick up and catch on as this new wave has come back through and start to recognize it is an important thing to do. But then you still get out and you still see some people that are just not going to do it, you know, and that's unfortunate.
Everyone else having a similar experience?
Yeah, I haven't seen my friends since March. They are not playing games at all, so they're not even leaving the house. But generally speaking, yes, it seems like at least my circle is wearing masks, but I will agree with Dr. Flanaugh that I ventured into a Target for the first time in months and was highly disturbed, aghast, flabbergasted, if you will, about the number of people who were not wearing masks. It's unfortunate. And I think going back to the question you asked earlier about some of why we as a community are at higher risk of spread is also because we oftentimes are on the front lines of other work. So we are on the front lines at, you know, the nursing homes. We're on the front lines at the grocery stores. We're on the front lines at the restaurants. We're on the front lines in a lot of other places other than healthcare. And when our fellow community members are not respecting us by wearing masks, you are putting someone at risk. Even if someone is wearing a mask, I think that's really important to know. If I'm wearing a mask and you are not, I am still at risk of catching COVID. So the mask does not protect me from you, it protects you from me. And I think that's really important for people to recognize. Right.
Yeah. And it's going to be a behavior change. Remember, the paradigm is shifting, or our behaviors are shifting, whatever challenge, there's opportunity. So learning a new behavior among anyone, even healthcare workers, wearing a mask at the hospital is difficult to catch on. So I think that if we just stay the course, again, like the doctor said, it's not completely preventive of the spread. However, it's protective in certain situations. But again, our behaviors have to change on a daily basis. And it's hard. And even for me, I forget my mask. Oh, I forgot my mask, X, Y, and Z. So I have to get in that cadence of wearing my mask, even in public.
My youngest son jokes that I'm the mask dictator because I don't let anybody leave the house. I don't let anybody go anywhere without a mask on. And I got 2 or 3 boxes of masks in my car. So he gets on me about that. But I still forget it myself as well. Talk a little bit about testing. Now, if you all weren't working at the hospital, would you know where to send a patient to get a test?
I would.
You would?
I mean, well, you can't get it as quickly as Dr. Waz can test you if you come through the ED or Dr. Bull. But there is I know at the department.
Well, you don't count, Dr. Drayton, because you're an infectious disease doctor.
But even if I were to order it for my patients, LabCorp and Quest, you have to make an appointment to get in there to get the test done. You can't just show up, just same as it is in the court system and all over town. There is a search engine on the Department of, Public Health's website. And of course, lots of people are trying to get appointments at CVS. 3 weeks ago, before this big, resurgence, you could get in the next day to CVS. But now, of course, even people, because there's a resurgence, people who are asymptomatic are trying to get in. People whose grandchildren may have, tested positive are trying to get in. So it's a little bit harder to get that kind of quick appointment. And I've gotten a couple of texts from people is, where can I get one within an hour? Can't help them with that unless they have symptoms, you know, maybe they can go to an emergency room or urgent care center.
At one time, Georgia Tech was doing tests, and then there's some at the Department of Health. There's some locations. If you go to the Georgia website, there's also at one time Augusta Medical College was doing, and they actually had an app that was that you could use at that time, but I don't think that they're functioning anymore.
Right.
And so it's kind of hard. And now I'm finding that our turnaround time in the ER was 2 days. Now it's 3 to 4. But when I meet patients that are getting their tests before they come to the ER, the turnaround time is about 8 to 11 days. So it's increased dramatically. And it's pretty much almost to the point where there's no public benefit of getting a test result 8 to 12 days from now.
Right. In fact, our mayor here took her 8 days to get her test done. If it takes the mayor 8 days to get the test back, then you know it's a problem. But one of the things we've been trying to do at the Atlanta Medical Association is to try to connect all the dots, because I've spoken to a lot of physicians who really don't know where to send their patients to get testing done. And each of those places that you all mentioned, they may be testing this week and not testing next week. And so it's very hard for the patient. If it's hard for the physicians, you know it's hard for the patients. We try to get the churches to be the backbone of the testing like they're doing in New York. And we're having mixed results with that. It's a lot more political, even dealing with the churches, than I thought it would be. But we are making some headway. And we hope to be putting up on our website very soon a list of where you can go and get tested every day for the next several weeks, because this is not going away.
When you get to questions, you do have a question waiting that's about church, choirs, and the like.
Where I don't see where is that question? I don't see that question.
Under Q&A, I think there's some questions.
But
under Q&A, I'm looking in the chat. I'm looking at the chat. Okay.
While you look that up, let me just sort of comment on that a little bit too, because this is something that we've looked at from Morehouse for a while, is the availability of tests, and not just availability of tests, but are the places to get tested available to those populations which are most at risk, right? Because we've seen, especially in the South, that the African American population has been very hard hit by this disease process for whatever factors. I think not only is it sort of a socioeconomic and lifestyle problem, but also I think there's some underlying, responses to inflammation related to disease that occurs. And then in the Southwest, you've seen a lot of Hispanic populations, and then you see different plants somewhere else. But those populations seem to be the ones that aren't getting availability of tests and rapid availability of the results back. You have political offices that can get tested multiple times a day and have results within an hour. You have sports elites which can get tested, right before each game, after each game, and whatever else. But then you have populations which are hardest hit, which are the most at risk, that don't have the availability to the test, don't have the knowledge of where to get the test, and the results often come back delayed, which, if you have an infected person or even an asymptomatic carrier, poses a risk of spreading to other family members by the time they even find out that they have the disease or they are at risk.
Right, absolutely. And there are some strategies being developed right now to address that very thing. How do we get the test for the people that need it the most? We do have a question here from Courtney Lewis. Atlanta has many Black churches of various sizes. What is your medical opinion on people attending church services and singing in church in light of COVID? What is the risk? Who wants to? And I can't see behind here, but
I'll take part of that, and then we can go from there. I think there is a significant risk, especially from the singing. You have very close quarters, and yes, it is. Let me step back a minute. Black churches, African American churches, yes, at high risk just because of the way the disease has affected this population here. But I think any church setting where you have people in tight spaces and you have a lot of vocalization, because this is spread through droplets, just droplets through regular speech. And now you have people singing at the tops of their voice, belting out some nice tunes, and they're just sending out COVID into the area, which puts them at risk. So that is something to consider as a potential risk for patients and exposure.
We've had an opportunity to do some webinars for several different churches, several different denominations here, and it's amazing the questions that they have, particularly in our Black churches. And by the time we finished talking to them about all the risks and the risk-benefit ratio, every one of them said we're not anywhere close to ready to open the church. So I don't think that's something that we're going to see in the Black churches anytime soon. They all say, you know, we are not ready to open the church, which I think is smart. We have some more questions, but I want to get into some of the kind of, let me see one more question here. Is it your recommend? We'll come back to, that's a testing question. We'll come back to that. Tell me, first question, like, are you afraid as a frontline healthcare worker? Are you afraid to take care of these patients? And that's on any level. I mean, physically afraid, emotionally afraid. Are you afraid to take care of these patients? Dr. Bullock, why don't we start with you? We're going to get everyone on this one. Please make them brief so we can hit everybody. You're mute.
Okay. I think not to be afraid would be to not understand the virus. The virus is highly contagious. It's kind of Russian roulette, who's really going to get sick or not. You have 20-year-olds that are fighting for their lives. So to not be afraid of the virus means that you just don't understand the virus itself.
Okay. Dr. Drayton?
I agree. I mean, it's, I feel young, but I start thinking about my age when I see patients come in who are younger than I am, who don't look very well. And, you know, you start kind of weighing your own health, you know, against that of patients who are in a, you know, high risk. So it's, does make you think about your own mortality, but, you know, this is the road I chose, so.
Dr. Flannel?
I think at some level you have to keep a level of fear. We've seen a shift in the patient populations that are affected. We're learning new things each day. And I think as soon as you don't become afraid, then you become more comfortable, right? And you're more comfortable, you become lax, and you're not as preventative, you're not taking your precautions. And I think that's when mistakes happen. We've seen over 100,000 healthcare workers get infected from this disease. We have more healthcare workers that have died from this infection, this disease, in the past 6 months than you had police officers die on the job in the entire year last year. So this is something that is more deadly and affects the population, which is intended to help you get better, affects them very deeply. There's significant risk to it.
Mm-hmm. Dr. Adequate.
I'll say, you know, yes, and I think just the generalized kind of fear, anxiety, hypervigilance exists chronically, as everyone has spoken to. But I think, you know, I actually feel safer in the hospital than I did at Target. Mm-hmm. Reason being, everyone in the hospital is required to wear a mask. Everyone in the hospital, generally speaking, is on very high alert. Target, people were touching all the supplies, wasn't nobody wearing a mask. It was wild. So I think it's a double-edged sword. But taking care of the patients themselves, I actually feel safer in the hospital than outside.
Dr. Wise.
Yeah, so, you know, it's extremely a challenge to take care of these patients, especially, I think we all had a sense, we signed up, you know, to take care of people regardless their ability to pay, especially as emergency room physicians, regarding their class, station, or wealth, and just to try to be the advocate for patients who, you know, need to go out and take care of their families. You know, you need to comfort them. People come on with anxiety, mental health disorders, kind of exacerbated by people coming in thinking about COVID, can't sleep, and they kind of, you know, snowball. So the emotional strain is among, not only among our patients, but also healthcare workers too, and our nurses and our environmental services and our secretaries. So this inflicts all of us mentally, and we just got to stay strong and stay the course, and to have faith and have belief in what we have to have faith in the things that we can't see. That makes sense. Believe in tomorrow. So every day is a redemption. So, just try to encourage patients to stay strong as we get through this.
And that's a great segue into my next question, Dr. Waz. We'll start with you this time. Can you give us an example of an experience you had that was probably the lowest moment that you've had thus far in taking care of patients with this disease?
Yeah, I just had a patient who, unfortunately, was a very young person, less than 40 years old, who was in Albany, Georgia, as the crisis started and the pandemic started, and, was seen in urgent care, came in with, vague symptoms, sounded like it was COVID-19, and, everything kind of mashed up, and came into the ER in a respiratory, actually a cardiac arrest, i.e. Us doing CPR on this patient. I think it was hard because his family, he was really healthy, in the sense that, he had minor comorbid condition, respiratory issues, but just a toll on the family, just to see that pain in their eyes of somebody who was just walking and talking, and who unfortunately succumbed to what appears to be COVID, especially with going back into the history as it presented down in Albany and urgent cares and kind of things. I think that death itself, sometimes we see as a mercy, but to kind of deliver bad news to a family of a young person who kind of succumbed is always hard, and it's never easy. And just, again, I just thank God for a higher power, for me able to be a burden bearer for others, but also for my health.
And being an emergency medicine physician and knowing the places that you've trained and were educated, I mean, you see death and illness all the time. But what was different about this situation that it just really stuck with you? What was going through your mind as you were experiencing this?
I think just because I think all we don't know about COVID, I think that makes sense. Like what we don't know about COVID-19 and what we don't know about this illness, Dr. Fanaz, stated this disease process and what we're learning from the pathophysiology of it. But I think just the sheer idea of someone who, who waited at home, who didn't come to the emergency department, who avoided the ER because of the lack of ability to care, who kind of waited to the last minute to come see us because they didn't want to, because of financial burdens of the emergency department. So all these factors kind of, put, I'm really on a crusade if I can just try to change the paradigm, try to help people access to care, and it really bothers me. It compounds everything, especially, being the COVID-19 kind of afflicted this young man. So we got a long ways to go, but I think we all here like-minded individual up to the task.
Dr. Adegweme, same questions to you.
Repeat the question. It was just what was like a lower point in all of this?
Yes, the lowest moment that you remember to this point when you were emotionally distraught.
There have been a few, but the most recent was actually last week. I had a patient who, she was in her late 40s, similar to this new demographic that we're seeing, Hispanic woman who had just lost two parents to COVID. So her two parents had just died. She was in the hospital for what was presumed to be COVID. She was hypoxic, short of breath, kind of classic symptoms. And I had to speak with the patient's daughter, so the granddaughter of the two who had passed. And she actually was stable. She was on a couple of liters. I had just met her, however, and the daughter was just beside herself. And it was one of the most heartbreaking conversations, not so much because I had to break bad news to her, but just the terror, the sheer terror that this poor child had, that she was going to lose her mom and her two grandparents within a period of 2 weeks, and really having to hold her through that, but also kind of hold myself together was really hard, because the reality of it is I don't know what's going to happen. Like, these patients, they will be on 1 or 2 liters and they'll be fine, and then they crash 3 days later, and they crash quickly. So I'm telling her, things are fine right now, but in the back of my mind, I'm like, your fear is well placed. And it's just really heartbreaking to see that, and just on a regular basis keep happening. But that was one of the more profound moments that I can recall.
Dr. Flanell, you're in the ICU, you see this, you see the extremes of it.
Yeah, I think one thing well, there's a couple of areas that come with this that become really hard from the experience. One is, and I can't isolate to just one patient. It's pretty much all patients with this, and that is that they're alone. I mean, because of the biocontainment efforts that we have to make to keep from spreading to community and also to other healthcare workers, we have to limit foot traffic through the hospital, which means no visitation. So you have extremely ill patients. You see that some of them aren't doing well, they're not going to make it, and they go through this alone, right? If they can get a FaceTime with the family, that's kind of a little bit helpful. But the families are in the dark about what's going on. You're not able to visit. They don't hear that one-on-one. Here's how today went, and can see the difference and changes when it's either good or when it's not going well. And so to have to explain to somebody, their family members, that the patient's not doing well, and this is not like an immediate, dying process. These patients this disease process, we have them in the ICU 20, 25, 30 days, but just in the intensive care unit. So those aspects of it, that day to day where they're in the dark, they don't know minute by minute, they can't visit, they can't hold a hand or that's one of the hard parts of this disease process, that the patients will do well alone, they will die alone.
Do you think that we need to do that differently? Do we need to look at, we know how contagious the disease is, but at the same time, someone may be literally on their deathbed. Should we take a different look at that and say, well, maybe there is a different way that they could spend a little bit of time with them, or is it too much of a risk to even think about doing that?
They've come up with some methods in some extreme cases of getting families being able to come in for a limited time and limited numbers, putting on appropriate PPE and being supervised to be with the patient. But you have to remember, if you have a 10-bed, 20-bed, 30-bed intensive care unit, and you have designated as a COVID intensive care unit, that every patient in there has this virus. Every bed, every area near it may have secondary contamination. So to do that on a large scale basis means you have a lot of foot traffic through, and these patients' families may coming through, may touch something, may get, find themselves in a room that's covered with it. They touch, they get infected, or they go home and they carry it to someone else. So it's really a hard balance to figure out how to do this without being the cause of an outbreak, either in the hospital or sending someone home to a household.
Dr. Drayton, this is your world. This infectious disease, this is your world that you're with every single day.
We do, as Dr. Flanell said, when we do know that a patient is doing very badly, we do have a process by which, family members can come to the bedside. Again, we have a COVID unit. I'm in Wellstar South with Dr. Waz. And, it can only be one family member at a time, typically. It's very difficult. And of course, it's hard on the patient who's aware that their daughter or their child can't come, but it's very hard on the family because, sometimes there's, particularly in our community, a level of suspicion any old way about what we're doing. And so it's very important that we communicate with them. We just had a medical executive committee last night, and we are really going to try to make sure we at least have a nurse or someone contact that family member daily if possible, but certainly every other day, if just to take my phone and show you the person or tell you that they're doing okay or that they're stable and haven't done any worse. So we're really, that's a big part of what we're trying to do, certainly at our hospital, at least be the conduit through which, the families can keep in touch with what's going on with the family member.
Dr. Bullock.
For me, it's sometimes knowing that I will be the last person this person talks to before they're intubated, meaning being put on a respirator. But recently, it became even more personal to me. One of my friends' husband was in the ICU, and she was expecting a call from the critical care doctor and put me on the phone with them. And it ended up being the palliative care doctor instead of the critical care doctor. But what they wanted to do was decelerate the care. And at this point in time, he had an increased oxygen demand, but no failure of any of the other organs. And it made me realize that sometimes there's an implicit bias, as Dr. A was saying, where we are sent away or we're written off a little too fast. And it really became personal. It really hurt and made me wonder how many of us are sent away from the ER or written off in the ICU as though as that we will not survive, just because there's a lot of implicit bias. When someone maybe of another race, they would try a little harder. But I just knew that my friend's husband, 50 years old, and only had lung failure, and that's COVID. COVID causes lung failure and no end organ failure, and not needing any pressor support. How do we get to this point of saying we should decelerate care and just stop care? And that was hard. That was hard for me.
That's important too, because if you have to be at a center that is accustomed, as accustomed as you can be in 4 to 6 months, treating these patients, because it is a long process to come back. I mean, I've seen patients sit on Vapotherm, not intubated, but sit in the unit for, it was almost 2 months, and just one day things turn around and they get to the floor and go. So you cannot give up on these patients that quickly, particularly if it's just lung disease. I mean, not just lung disease, but and that can be progressive to the point at which we can't help them. But if they're sitting there stable and they're on 10 liters, or you've been able to get that vent down to 80%, be patient, because some of them will just, I don't know, it has to do with the immune response, but they'll start clearing it and get better. You can't really, you have to wait a minute, when you're taking care of these patients.
Yeah, Frank, and you know this too. I mean, I would gladly take a patient with 1 organ failure and buy time rather than having 5 organ failures.
Mm-hmm. Absolutely. Does this put more pressure on you as a physician? I mean, we all go and we like to read about our patients and the workup and diagnosis, but does this make you go home and read more articles, or make you go home and think about new strategies, or even make you think about what can I do to help this family? Does it put added pressure on you in any way?
Every day, especially when it started. If you just track what we learned about potential treatments and how the disease presented, we've seen a complete 180 from where we started to now in terms of treatments. I don't want to get into the chloroquine process and whatever else, but what was initially touted as going to be the wonder drug didn't really pan out that well once we really got knee deep into it. You also have to look at how it started in the different populations that are affected. It started out in China, and then from China you have a lot of patient demographics, ethnicities that we have here that aren't present there. And then it went to Italy, which is a different patient population presented in an entirely different fashion. And then from there, and in South Korea, and now we're seeing, even in the United States, different areas of the country, different presentations. And so we've had to keep up with that. We have to read on that on a daily basis. There's new trials coming out. Some have been successful. Some show a little bit of benefit. Some show a little bit more potential, but are not as available, convalescent serum as an example. And then there's new things coming out each day. Now we have, steroid.
We're going to come back to treatments and everything in just a minute. So good. Hold that thought, but continue. What else you're saying?
Yes. Yeah, so that's that. So it is, if we're going to treat patients with an ever-changing disease, we have to keep up with what comes out on a regular basis. I get weekly, read the weekly journals out of JAMA, just trying to keep up with what's new and what hasn't worked and what's available.
Mm-hmm. I totally agree with that. When this first started, I was feeling some kind of way. because I really was accustomed to my medical knowledge. I was very comfortable. I knew what I knew. And if I didn't know, I would call a consultant. I would call Dr. Drayton, or I would call a Dr. Flanaugh or somebody to help me. And I couldn't do that because nobody knew what was going on. So we were all learning together, which was fascinating in a sense, but also highly disorienting and a little bit frustrating because, again, we get used to knowing what we know. And I didn't want to go back to residency, but I felt like I was back in residency. But I did also learn the need to, I think this amplified my desire to be an advocate for our patients. I think that we, because of this visitation policy, are very much their advocates right now because their families are not there. And I think that has been another kind of learning in this, in addition to the medical piece as well.
You know, I've shared this, I guess, on a different call, but you know, I'm a little bit more comfortable during this little surge. And I'll just tell you my experiences that I've seen. You know, I might have had 6 or 7 20-somethings with a few 30-somethings in it one time within the last week. I lost a brother and sister within a week of each other. The vast majority had BMIs of 35 to 40. I mean, I don't, you know, this may be peculiar to younger, many of the young folks sat on 2 or 3 liters. Some left, but they all seem to, you know, have obesity as a common denominator. But I think that we, particularly as we'll talk about Decadron later, but remdesivir, you know, other medications are available. We know about ECMO. We feel a little bit more comfortable. It seems that we had a surge, but we seem to have fewer deaths, perhaps because they were younger. I don't know. But during the first surge, I understand what my colleague says. It's this feeling helpless. And I tell people the reason I went into infectious disease is that I didn't want to follow your blood pressure for 30 years to prevent a disease you may never have gotten if I can manage that. But infectious disease is one of those things where you're sick, I come in, I get immediate gratification because you're off the pressors and or, you know, I like that. I'm a Gemini. So feeling helplessness, you know, as you watch the patients and my pulmonary colleagues, I can tell you it was, you know, quite a growth experience, because after I offered the little few things I could offer, it was the pulmonologist or the lung doctor who really held their hand, and even into their transition, those who passed. And it was hard on us, and we try to be tough. But I can tell you that at WellStar, we started, you know, periodically sending each other, you know, our favorite gospel song or something inspirational in the morning, because we try to be tough and think it's only the patient and the family going through it. But, you know, we were going through our own stuff as well.
Absolutely. We have a question, and please, we want to tell the audience to please reach out to us through the Q&A section. And we have a question, and Priscilla, you want to let them ask that question live? The question about, oh, where'd it go? I lost the question. Oh, okay.
Yes.
Oh, this is actually my brother asking this question.
If he wants to acknowledge it live, and if any of the attendees, if you want to ask a question live, let us know. We'll be more than happy to allow you the opportunity to ask the doctors these questions.
Vernon Keith Jones in Augusta, Georgia. How are you doing? Would you like to ask this question live? He likes to talk, so I'm sure he would.
Hello, folks. Can you hear me?
Yes, we can.
Okay. Hi, folks. Just a question. Oftentimes you hear now, particularly, that certain patients aren't able to get in to actually see doctors because there are just so many people that are actually coming in to be seen. Are there any, and I guess the best way to ask it is, are there any buzzwords that will cause you to consider patients really being in need of actually being seen versus being sent home from treatment or something like that? How can a family member best advocate for that patient to be able to actually be seen?
That's a great question. Thank you for the question, Keith. And I've seen patients that come through my clinic with pneumonia. I mean, they have pneumonia, they're septic, they were in septic shock and got to the hospital. I said, oh, did you get tested for COVID? Oh, no, they didn't test me. I'm like, how could you not? And that goes back to the implicit, maybe the implicit bias. But are there some strategies that a family member could use to say, I want my family member tested for COVID?
I think one of the things that a family member can do is make sure when you take a family member to the emergency room or to the hospital that they have a charger, a cell phone, and a tablet. And sometimes during the interview when the doc is in there, you can actually be on that tablet with them. Now, if the patient is intubated, that's a different story. But if the patient is able to speak, just being on the call with the patients. I've been on a call several times with patients and their families because the family can't come in and the family had questions. So I think that is just making sure they have a charger and a cell phone.
But what about that patient that goes into a clinic? The patient themselves, they go into the clinic or the doctor's office and they're doing fine, but they're really concerned. I had a fever of 103. I couldn't smell anything, but yet they have difficulty getting their doctor to order a test for them. What should they do?
I think a lot of times when patients come into doctor's appointments, they kind of hold back, right? They may hold some of their symptoms back, some of their descriptions back, or they may not be aware that this disease has a lot of presenting symptoms that you may not fully understand or are part of the spectrum of complications and symptoms that they have. You know, in the early courses or cases that they had, and we've even seen them in our hospital, some of the patients came in with more GI symptoms. You know, so it's just nausea, vomiting, a lot of diarrhea. And they happened to get a CAT scan looking at to figure out why they were having such GI symptomatology. And then they find infiltrates in the lungs. So for the family members to be aware of a lot of the presenting symptoms and look out for them. And for the patients to be aware, we need to get that entire, headaches, just headaches, loss of smell, but a very defined frontal headache, fevers which come in waves and may go away, generalized muscle aches. All of these symptoms need to really get across the communities that these are presenting symptoms. This could be, and then they need to present them in that fashion when they go see the physicians. And one thing to be careful, I'm just going to say this, as we start looking at whether or not going back to school is safe or not, we got to look at some of the, the pediatric inflammatory multisystem syndrome associated with COVID that they've seen in children, because it's a little bit later age than you'd expect. The classic Kawasaki's we hear, about the median age is 9 years old. So knowing how these symptoms will present and what to look for in your children as we move forward into the school year is going to be important, and being able to present those to the physician, whether it's a virtual visit and you're jumping on the call with them, or you may have to call the doctor or jump in and say, hey, look, no, this is what's really going on. They may not understand it. We have to get that message out.
Okay, we're going to try and go through some of these questions. We got a lot of questions popping up now. Let's try and get through several of them kind of quickly. We have a question from Carmen Lita Scott. Very good question. Carmen Lita, would you like to be live? Would you like, Priscilla, could you unmute her and see if she'd like to be live, or would you like for me to ask the question?
She can go ahead.
There you
Okay.
go. Dr. Jones, thank you very much. If you take—
And tell us where you're calling from, please.
Dr. Jones, I'm calling from Atlanta, Georgia, in specific Peachtree City.
Okay. Welcome.
Thank you. If you take the antibody test and the results are negative, what exactly does a negative result mean? And if you have antibodies in your system, how long are they actually there?
Great question. Great question. Dr. Drayton, why don't you handle that one for us?
If you don't have antibodies, typically that means, that you weren't exposed to the virus. The longevity of the antibodies, I'm not too sure, and I'm not too sure anyone knows. Based upon antibodies to other coronaviruses, they tend to be longer lasting than to the flu, which is a changing virus and the like. But, you know, we'll have to see how things go with this one. I think with SARS-1, antibodies were pretty long lasting, and, you know, you'd have some memory that you'd seen it before. So we can only hope that this is the case with this, which is SARS-2.
So break that down for us I'm sure we have some enterprising high school students listening to us. And they want to know, what's the difference between an antibody test and a PCR test, a ABC test? What are the different tests and what do they mean?
Well, the diagnostic test that we use for acute disease when you come in and you have symptoms is what we call a nucleic acid-based test. So PCR or an NAT test detect the actual genetic material of the either an antigen, which is something on the surface of the virus, or genetic material of the virus. So you're actually wanting to get a piece of it to prove that it's there. On the other hand, antibody tests are really testing your body's response to an infectious agent. So once I have an infection, my immune system is going to make an antibody that fights that infection. And that's what, you know, we're measuring when we measure antibody. And typically for this virus, within about 7 days, you'll have the first type of antibody that the body tends to make. And then within about 14 days or so, there are 2 types of antibodies to make against it. So within a couple of weeks, we're typically able to detect that your body is producing antibodies to fight the virus.
So is it safe to say that if you do an antibody test and it comes back negative, that you have not been exposed to the virus?
That has to be our assumption at this point.
Okay. Unless you're dealing with a bad test. And that's the other thing. There are a lot of bad tests out there. But that is the assumption that we have right now, Ms. Scott, that if you get a negative antibody test, then you probably have not been exposed to the virus.
Thank you very
let's
much,
see if
sir.
Say it again.
Thank you very much, sir.
Oh, thank you. Thank you. Let's see. How do you feel about, there's no name on here, but how do you feel about fitness centers reopening? Is it the same as your opinion about reopening the churches? I think probably broadly we could say probably have the same opinion about that. I don't think that's too controversial. Let's see. I want to shift gears a little bit, and let's talk about treatment, new treatments that are on the horizon. Dr. Flanaugh, can you kind of start us off with that? And first of all, being a pulmonologist, we hear the term a lot, proning a patient. Can you tell us what that means to prone a patient and how that can be helpful?
So when I mentioned a little bit earlier that you just get a lot of inflammation and it causes fluid to leak into your lungs, okay? And so a lot of times where patients are positioned in the intensive care units or even at home before they're intubated, they sleep on their backs. And you gotta think, if you have a lot of water that can redistribute, it's gonna collect in one area of the lungs. Basically, it's heavier, so it falls down and air goes up. And that kind of makes it a little bit harder for those areas to have good gas exchange. So when we shift it, we actually, and then prone the patient, so now you have them sleep on their stomach or lay on their stomach, then it redistributes some of that lung water as we work with different methods to decrease the inflammation and get it off. But it allows other areas to exchange gas a little bit better. Those areas that were filling up with fluid from being in one position now redistributes, and now it allows better gas exchange. And so we leave them on their stomachs for a while, then we'll put them back on their back and whatever. So you don't get one big area that for a long time period is not functional because it has a lot of lung water. So we found that's been very helpful in getting patients. And we actually discovered that because one of the things that when patients would come in and they're short of breath, they say, well, when I sleep on my stomach, it's better. And so that's how that came into part of the treatment strategy.
Let me just interject real quickly before you
go ahead.
Before you go on, to Dr. Bullock, Dr. Adequime, and Dr. Wise, in the emergency room, or even when the patients are on the floor, are you proning your patients early? Some people advocate proning them as soon as they come in the hospital. Are you all doing that?
I've just been telling, I mean, interestingly, I've had a couple of patients actually say they feel more comfortable on their stomach, like without me even saying anything, which I thought was very interesting. But I've been recommending it. And also we have within our hospital, they actually have some kind of study or trial where they recommend that they do that. So most of our patients end up that way regardless, but so yes.
So, and again, so unfortunately, just with the emergency departments are, being boarding patients, we are proning patients in conjunction with the hospitalists and our IED doc and our pulmonologist in the ED. Also, we give self-proning instructions for patients we feel who probably can go home and kind of observe, because unfortunately, we just are inundated with patients with COVID who really need a bed. So we have self-proning instruction, and we also have doing proning in the emergency department of those patients who need to be admitted.
Dr. Bullock?
I've done proning in the emergency department, especially those patients who are not responding to high flow O2. So then we prone them, we just start them off right away, because we're getting to the point where if we can't figure out something to do, we're going to intubate them, and we're trying to do everything we can not to put them on the ventilator. And then the other thing I'd like to add is in terms of the antibodies, they did a recent, an article came out recently. There was a study, I don't know how good the study was, but it shows that the antibodies are fading, and the half-life is about 72 days. That means half of the antibodies will be gone in 72 days. But that doesn't mean you still can't mount an immune response, because you still have T cells and memory B cells that can help fight. But they don't know what that means right now in terms of antibodies fading in about a half-life about 72 days.
Right,
Okay.
and it is a virus, so the primary means of defense is cellular immunity, really,
Okay.
not humoral. So
Yeah.
Okay. And we're going to come back to you, Dr. Frontline. But first, I just want to remind everyone, this is Ask a Black Doctor, sponsored by the Atlanta Medical Association. Please fill out the survey that you received. We're trying to just find out what's happening in the community in terms of wearing masks and what your understanding of COVID is, so that we can help develop some strategies. And there's also another little poll at the end to let us know how we're doing and what we can do better, just in terms of delivering you the information. There's another question in the question and answer period by another friend of mine, frat brother, Stan Pascal. He's asking about over-the-counter treatments, and are there any over-the-counter treatments? And let's talk about that and frame that into what are some of the other standard treatments. Is anybody aware of any over-the-counter treatments that are being used?
I have not heard of any over-the-counter treatments outside of those that you'd have for just general symptomatic care. I mean, fevers and antipyretics or anti-fever medication, Tylenol or some of the ibuprofen, but I haven't heard anything specifically for targeting or treating this disease process in general. Recommendations that you can do in terms of general health, vitamins, and they've looked at, vitamin D, vitamin C, some zinc levels, but nothing specifically to target the disease process. Dr. Drayton, I don't know if you've heard anything.
well, there would be nothing I would say was a cure necessarily, but and I have to say that early on and even now, it's advised that you avoid ibuprofen and nonsteroidals, and the logic of that is that the antigen on your cells that the virus uses to attach to the cell and get inside is increased in number on the surface of the cell by non-steroid. I don't know if that makes sense to the public. Doctors get what I'm saying. So it was a soft recommendation not to use those, and maybe use acetaminophen or Tylenol. But one thing that I did early on when we had very little in our little clinical box to treat folks is I would go to clinicaltrials.gov and look at what other folks were looking at, particularly nutritionally. And there were quite a few studies nationally that were looking at vitamin C, vitamin D, selenium, and things like that. And of course, when we were using the other HC, unmentionable, I guess, we did use zinc with that, and zinc is good anyway. And I happen to kind of suck on some Coley zinc lozenges.
I believe in zinc. I use zinc all the time.
It does keep viruses from sticking to your throat. That's what they say. So it can't hurt me. It's a supplement. So, but I did tell you this though. There are studies that they've done with sepsis in general, not just this infection, that have shown that patients who do not have vitamin D deficiency, who have adequate vitamin D levels, do tend to do better when they have the potential to develop SIRS or systemic inflammatory response or sepsis. There's really no evidence that if they're deficient and you replace it at the time that they're sick, that it's necessarily going to help them. But I do measure vitamin D levels, and people of African ancestry do tend to be deficient because we have this wonderful melanin, and we're indoors now and not getting a lot of sun. And so I've noticed that a lot of patients had levels of 6 and 7, and since it's a nutritional deficiency and it wouldn't hurt to replace it, I would give some vitamin C and D and things like that. To these patients.
Dr. Jones,
yes.
Can I interject? So, I think that, and this is not necessary treatment, but this is just to all those who are listening. Again, I harp on this a lot. This is opportunity for us to change the paradigm in healthcare, how we take care of each other, how we take care of ourselves. As Dr. Drayton, Dr. Fernald talk about vitamins and all these supplements. Let's just get healthy. I mean, hypertension, diabetes are inundated in our community. Some may be genetic predisposed, but we gotta be the master of our own fate, captain our own soul. We gotta take care of our health. And I implore you to start eating better, start exercising, start drinking more fluids, start getting rest. We may not have the cure to COVID or the avoidance of COVID, but what we do have and what we can control is your diet, your health, and your opportunity to take control of your health itself. So, I know COVID is there, but hey, at least you put forth an effort. Even if you get it, you know what? I tried. I did my vitamin C. I've been eating well. I've been seeing my doctor. I've been taking my blood pressure medication. I've been taking charge of my health. So you can control that. You can. So, we may not have with all the answers, but this is really, an opportunity for you to listen, take heed, and, kind of take better health of yourself.
Well said. Dr. Adegweme, when patients come in and you're at the hospital, so you admit them to the hospital, what kind of medications are available to you in your toolbox? Before they get to Dr. Flano.
Now you're not talking about hydrochloroquine, are we staying away from that, right?
Oh, you can talk about it if you want to.
I would rather not.
Do you use it?
Absolutely not. I refuse.
Do you take it every day?
I do not. No, sir. Me and the bleach and the hydrochloroquine do not get along. No, so we right now, the current recommendations are, at least in my facility, are mainly Decadron and then remdesivir, and based on certain clinical criteria.
Tell us about, what is Decadron? What is that to the listener out there? What is Decadron?
Dexamethasone, which is it's a type of steroid, basically.
Okay.
And so we're current recommendations call for, and correct me if I'm wrong, Dr. Drayton and Dr. Flannel, but I believe it's 6 milligrams for 10 days, 6 milligrams daily for 10 days, at least that's the protocol at our facility, either PO or through the IV. And it's for, at least again, and I don't know if they have facility specific recommendations for this, but for ours, it's for a certain level of oxygen that would determine whether or not they were to get it. And then the remdesivir it's the same thing. It's basically a certain level of oxygen and other clinical criteria that would determine whether or not they get it. And then the other thing I just forgot is also the anticoagulation or the blood thinners. So that was a big thing. And I actually remember in the beginning of, like the very beginning where everyone was scratching their head trying to figure out what this was and what it did. I remember multiple people saying, do y'all notice that these people get a lot of blood clots? Are y'all noticing that? So it's like we're seeing real time the recommendations come forth. But also there are certain parameters for which we give certain doses of anticoagulation or blood thinners. Okay.
And Dr. Flannel, you were talking about the inflammatory response earlier. Can you tie that together with what Dr. Adegweme is saying and why those medications are effective? and how effective are they?
So, I'm going to stay away from the hydrochloroquine because even in the beginning when it was highly touted, we were using it in the beginning and just was not seeing what the effect that we were expected to see. And then later on, it panned out. The studies didn't show that it would be able to deliver what we were thinking. The inflammatory response and a lot of the complications of the disease come from the response that it triggers from your inflammatory system. So what the thought process is if you can suppress that a little bit, and that's what the Decadron or the steroids do, is they suppress some of that response, then hopefully you won't have as much sort of collateral damage from your own body responding to the virus, making things worse. So I've seen a lot of benefit with the Decadron, keeping the lung inflammation and inflammation throughout the body down and being able to get them off the ventilator a little bit easier. The remdesivir, it's not as much of a survival benefit. It's been shown to decrease more so the length of time on the ventilator. But I can tell you, any day that you save being on a ventilator is beneficial. So it had a trend towards being effective in that way, and that's helpful. There's a lot of newer medications, new therapies coming out. They're still in trial phase. We'll just kind of see how those go as some of the more of the studies come out. One thing I did see recently for those patients that aren't as severe in the intensive care unit, but still having difficulty in breathing, a study out of Dr. Bartlett did this out of Arkansas. It's inhaled steroids. Some of the treatments that's used for asthma. That's a lesser, smaller dose than the Decadron. But for those that are not severely symptomatic, that's started to show some benefit, maybe for those patients on the floor that are having a little shortness of breath, and we'll see how that pans out. Definitely the anticoagulation makes a difference to keep their blood thinned, especially if they're prone to developing clots or they've actually developed clots coming in.
Yeah, there are.
Dr. Flynn, I am convinced that hyperbaric oxygen therapy, we don't have time to talk about that now, but I use a lot of that in my wound care. I am convinced that we're going to figure out one day that hyperbaric oxygen therapy can treat all of this stuff. The biggest concern is how do you clean the hyperbaric chamber after it's done? But I think we shouldn't be worrying about that if we can take care of the patients. But that's a different. I'm gonna get off of that pedestal. But Dr. Bullock, so a patient comes into your emergency room. What is your protocol? Let's say someone's pretty sick, but they're not ready to be on the ventilator.
Well, Dr. Jones, yes. Can I mention two other things?
Yes.
One is convalescent sera.
Okay.
And there are some exclusion criteria for remdesivir. I have a better experience with remdesivir than probably Dr. Flano, because he's seeing folks when they're really either close to the vent or on the vent. But when they get to high flow oxygen or 4 or 5 liters, I've just seen people kind of turn around, and because I'm trying to avoid the vent. So we're proning, and when I give them that, we give a 5-day dose if they're not on the vent, and 10 days if they're on the vent. So I'm a little bit more impressed with it than you might have been reading the study that came out, in which showed that it decreased the days in the ICU by 4 days, but had no effect on mortality. But those were the sickest patients that they were giving it to. For convalescent sera, though, there are some exclusion criteria for remdesivir where I can't give it to the patient with cirrhosis, or I can't give it to the patient who's headed toward dialysis, but they're fairly early on in disease where giving them a little bit of convalescent sera, which has the antibodies in it, may benefit them. I don't know how much help the convalescent sera is to the patient after 3 or 4 weeks when they have their own antibodies, but early on, if I can't give remdesivir and I see that their oxygen requirements are going up, then we do that. The only other thing that's not a standard of care, but that I've used, is what we call an IL-6 inhibitor. And that's just an inflammatory mediator that we know is involved in this flooding of the lungs that Dr. Flano talks about. And I've seen that kind of help turn folks around if it's used fairly early. Okay.
Dr. Bullock, back to you. Do you have access to these things? Because a lot of the patients are so busy, are being boarded in your emergency room. What are you able to do? What kind of therapy are you able to start in the emergency room?
And in the emergency room, we're more focused on just acutely identifying what is going on, because when their patient arrives, a lot of times we don't know whether they're in congestive heart failure. We don't know if they're just asthma, COPD. So the main focus in the emergency room is to just first, let's figure out what's going on, and then to minimize the risk to the staff. So there's some treatments that we've been able to use in the past, for asthmatics, we use nebulization. But we also have to think, is this asthmatic also somebody who could also have COVID? And then it's just going to spread those particles in the air and infect our staff. So more so just being careful, and then doing with COVID, you want to do as little as possible when it comes to oxygen. So you just want to give them enough to make it and not be overly aggressive. Initially, we were overly aggressive because we'd see people and they looked pretty bad, but they're able to compensate for the low oxygen levels, even though they may look pretty bad. And the ones that board in the emergency room, they're still being managed by the hospitalist. So so they would actually still be under their care, because once they get to, we're still turning over new patients. So once they get to that point, it's better for them to be in the care of somebody who's going to take care of them long term.
If they've been admitted but boarding in an emergency room, and you're a hospitalist, Dr. Eddie Whitman, can you start remdesivir in the emergency room, or is that something that has to be monitored?
I haven't run into that before. I don't see why we would not be able to if the patient met criteria. Clinically, I don't see why we wouldn't. I just haven't quite run into that yet.
Okay. My chief operating officer who runs everything tells us what to do is that we're supposed to have a hard time to cut off, but we got a few more points that I would like to cover. So Dr. Hubbard, don't cut us off yet. A question coming from one of our members, one of our past presidents of the Atlanta Medical Association, Dr. Delphine Head. I know she wants to be heard. So can you put Dr. Head on Dr. Hubbard so she can ask the question? She's a family medicine physician, outstanding physician here in the Atlanta area, past president of the Atlanta Medical Association.
You're available to talk, Dr. Head.
Good evening, everyone.
Good evening.
So I have a question from an outpatient standpoint. For those patients who come in to the office, or they have an X-ray that shows may have COVID pneumonia, what is the treatment for that? And is there such a thing? Because in the beginning, we were told that pneumonia and COVID don't really correlate, but now I'm seeing most patients with pneumonia, it's determined that they have COVID-19. And what about treatment for it? Is Zithromax or prednisone options for those type of patients who don't need inpatient treatment?
Dr. Drayton, Dr. Flanoff, can you all answer that question for Dr. Head?
Let Dr. Drayton, you want to go? Because I can tell you, I don't do a whole lot of outpatient pneumonia treatment for these for the COVID patients we've seen, and I'm not sure that I would recommend azithromycin for a little bit of what Dr. Drayton touched on earlier, which was the difference between bacteria and viruses. But I'll defer.
I don't know, Della. Are you saying that they're testing for COVID, or the suspicion is that they have COVID in the outpatient?
For one patient, the radiologist actually said there's pneumonia that is consistent with COVID, like infiltrates, like bilateral infiltrates that are consistent with COVID.
Yeah, you know, I mean, I would treat, if the film looks like an atypical pneumonia, bacterial pneumonia, I would treat that. But you do have to assess the patient. Now, if the patient's pulse ox is low, and they may need to go to the emergency room. But and I know that it's kind of, the radiologists can overread. Ground glass infiltrates are caused by a lot of things other than COVID, but today that's going to be the reading. So I would err on the side of being really, really careful if that patient is, you know, has low oxygen and that's not the norm, and, you know, ask them about whether they smell, they can taste, and kind of do that whole little questionnaire.
There was a study from a group in New York of radiologists who, and this was way back in March, they looked at like 200 CT scans.
Yeah,
and they were able to, it was very sensitive, looking at CT scans that they could determine that it was COVID.
But it's a classic progression of the CT. So, one CT in time can be very classic for that. But now ground glass opacities are, always, not always COVID, but they kind of reading it that way. But there is a very classic flowering. I mean, Dr. Flano can speak to this. The way it looks over.
Yeah, there's two.
But when they compared it to like ARDS, that gives you a classic. It was very different, and it was very specific for patients that had COVID.
Right. There's two classic radiographic presentations. It's called like an L and an H presentation. One is a very classic ARDS with a capillary leak, and there's a lot of inflammation with heavily interstitial infiltrates on a CAT scan. It's really dense. The lungs really prominent. The markings in the lungs are really prominent. And those are the patients that go into the bad respiratory failure. And then there's the other one, which are sort of lighter ground glass, what they say looks like ground up glass on the CAT scan, the more fluffy pattern that we see, which is sort of lighter. And those were very classic in those reads. I mean, it gave them a good opportunity to differentiate that. But you got to keep in mind where they were, and at that time, I mean, New York was seeing thousands and thousands of cases, and their radiologists were seeing quite a few. So they became experts in that. If you take another smaller hospital with a radiologist there, they haven't seen as much. There might be times where it's overcalled or undercalled. And so you just really have to go back to what Dr. Drayton says, go back to the symptoms and what your suspicions are. And that'll tell you whether or not you treat empirically for a pneumonia versus whether you truly think this is COVID.
Absolutely. We have probably about 9 or 10 minutes left. I want to acknowledge one of my former colleagues, Morehouse, Dr. Omar Danner, made a comment, and I lost his question now, but he made a comment about, where'd it go, Dr. Danner? I have lost his question, but he had a very good question, and I'll keep looking for it and see if I can find it. But Dr. Danner is a critical care doctor at Grady. He's in the trenches as well, trauma surgeon, general surgeon. Got to talk about school before we hang up. Dr. Flano brought it up earlier, but just by not a show of hands, but real quickly we go across, should students be going back to school in the fall? I know there are a lot of caveats, but just in general, your gut feeling, as well as your knowledge that you depend on, long-term experience, should we be sending our students back to school under the current conditions right now? Dr. Bullock, we'll start you. Please have some brief answers.
In terms of sending students, that's a hard question. And I think the reason it's hard is because we haven't been testing students, even the ones that are asymptomatic or have symptoms. So we don't know the prevalence of COVID in young people as of yet. And we haven't, if we had tested them and found out that some young people do have COVID and we could contact trace and see if they are actually infectious, then we would be able to answer that question. But I just think that's a question that's just very hard to answer without having done the proper research.
Well, let me put it a different way. If we somehow miraculously ramp up our testing and our contact tracing, we haven't even had a chance to talk about that. Maybe we'll have our next Ask a Black Doctor will be on that. But if you were comfortable with the level of testing, would you send your children to school right now? Got to put you on the spot. Yes or no?
I couldn't answer that because I just really think that they need to test and find out the prevalence and then see if they actually do spread it. If they're not spreading it, then I feel like it's fine for them to go to school. So it's a hard question.
And for the audience, we're not giving you advice. We're just giving opinions. So what was that? Yes or no?
I'm gonna defer.
We're gonna get you off of that fence.
I'm not gonna answer that.
We'll come back to you, Dr. Flano, and then we're gonna come back to you too, Dr. Flano, to talk about the inflammatory response in children. We got to talk about that before we go. But would you have some beautiful children? Are you gonna send them back to school in the fall?
No, I think given the timing, we're seeing an increase in the number of cases that we're seeing, and it's occurring in younger patients. And I'm not sure that we know enough about the disease or the direction that we're going, or that we have enough control over it, that I feel comfortable putting my kids, personally my kids, back into a situation that would be hard for them to social distance, keep up with their protective measures. I just don't feel that we're at the right place right now to completely trust the system.
Okay. So if you had to give, if the superintendent of Atlanta Public Schools came to you and said, Dr. Flanall, I saw you on the cover of Atlanta Magazine, and I hear you're a pulmonologist extraordinaire, and we want your opinion. Should we open up schools this fall? What are you going to say, yes or no?
I would say, one, I would not open up schools at this point in time. I would probably reassess it in another 6 weeks and decide if that's going to be, because I think in another 6 weeks, we're going to have an idea whether or not we're going up and down. But at this point in time, I would not. I would stick with the virtual learning and come back in another 6 weeks and decide, do we have enough protective measures? Have they set up the policies and processes to keep people safe, and that we can handle it for the rest of the fall?
Same opinion for college students. I have a upcoming freshman that is, and they say they're opening school in August. Would it be the same answer for college students?
Same opinion. I have a college student as well. And, you know, it's gonna, two things. I think they need to go back and look at the area and where the trend and the case numbers are in the area, and then what the school has set up for their protective measures. So that's going to be variable across the country. If I have a college student going to college in Florida, in Miami, I'm not sure I'm doing it, you know. If they're going in small town Montana, then maybe it is. So I think we have to be advocates for our children and look at the area where they're going, what the safety measures are that are in place, and then make a decision off of that.
Okay. Dr. Drayton.
I have a couple college kids, and I think that what I've seen of certain colleges that are able to do this is that everybody gets their own room, even freshmen. Of course, my younger boy goes to USC. They have a lot of resources, and they're only letting the athletes, because he's an athlete. And of course, some of the foreign students who needed to take a class in person to come back. My understanding at Clark Atlanta is that they want the freshmen to have the college experience. The upperclassmen have had that, and so they're going to do things remotely and let the freshmen come and have their own rooms. So, you have to get a feel for, where your child's going and whether they have a plan. And of course, different age groups are different because these are older kids. I can tell you, I've already heard, has been through a few of the teams at USC, and they've all had it, and so I just happen to know that. Now, when you're talking about 6-year-olds and 7-year-olds, are they really going to socially? That's just pretty unmanageable to socially distance. Fortunately, I don't know about other states, but you can opt to do that K-12 homeschooling thing in Georgia, which you pull your money out of the system, but I think you have to have the whole year's commitment. So if you were thinking, well, maybe we'll just do it till Christmas and see how things go, I think it does require that you make that whole commitment. And I will tell you this, if they're, most of us on the call have the resources to kind of handle the at-home schedule and some other things, but for families who don't, and they want to, and their school systems aren't opening up, and they have difficulties even getting the Title I meals or getting access to computers and all of that, there's a legal organization that will represent you for free with your school district, kind of help get those resources for you, depending upon what your school does. The ACLJ will do that.
And I think most of the schools in the Metro Atlanta area have come to the conclusion that they're going to go virtual. even those that initially were going to open up, even Gwinnett County is the largest. I mean, they've decided they're going to go virtual. I think Fulton, they're still trying to decide, may have a combination. City, Atlanta Public Schools is going virtual. So most of them are going to be virtual. Dr. Adegwime.
Yeah, based on what I've heard of what a lot of the schools, both in the university level and the K through 12 resource-wise have, at least in Georgia, it's a hard no for me at this point. I don't know what goes on in the private school system. I'm just referring to public schools and universities. It just doesn't sound like they're fully prepared currently, but you know, they can reassess later. But I would say no, period.
Dr. Wise.
Yeah, I think that I'm in favor, like, you know, when I let my kids go back, I think that if there was a better plan with in-person versus a hybrid type of model, with the, you know, or, you know, different ways, you know, hybrid model where certain students go on certain days, you know, maybe 1 or 2 days a week with, in conjunction with the computer learning. So, you know, I'm not in favor to go back as it was last year when there was no COVID. I think that we should be a hybrid and a better plan.
Okay. Just want to say thank you, Ms. Carmelita Scott, who asked a question earlier. She is the president and CEO of the ATL Airport Chamber. And I think we of the Atlanta Medical Association are part of that chamber. So thank you for your question and thank you for joining in.
Frank, can I ask a question about that?
Yes.
In terms of the schools, this is what baffles me. We have the means to actually take care of our children at home. But for those parents who are single parents, who have low income, who have 7 and 8 year olds, those people that do not have resources to have the internet, this is where I'm baffled is we can close the schools. Our kids will be fine, but what about theirs? Should there not also be an opportunity to go to school as well? Because these people don't have the same choices that we do. And I just think that there should be an option.
Yeah, and that is the dilemma. And so that's what hopefully we'll get some guidance on that. We have not gotten much guidance even from the CDC, and so hopefully we will get some additional guidance, but that is the dilemma. Eric, can you touch on very briefly, we're gonna head out in just a few minutes, but can you touch on the what you were talking about a little bit earlier, the inflammatory response that we see in children? You know, before, oh, children don't get it. You know, there's no issue with children getting COVID. There's no problem.
Yeah, we heard a few weeks ago, we heard it where children started getting it, and they were getting a disease or getting symptoms and findings that were similar to what's been classified as a, you know, Kawasaki's disease in the past. You get this red sort of purplish rash on their dry feet, cracked lips, and whatever else. And they started to see that coming up a little bit more in the children. And now there's recently in JAMA, there was another study looking at, it's one of the larger ones, about 58 patients that presented with it in children. And I started to see that the median age for these kids that developed this secondary to COVID was about 9 years of age, right? A lot different from the classic Kawasaki's, because those patients were about 2 years old. So these are school-age children that are developing it. About 69% of them were Black or Asian race. A good percentage, the majority of them were boys, but about 35% of them were girls. But you would see a wide range of symptoms: sore throat, conjunctivitis, cough. And then, so because you get this inflammatory response, you'd see swelling in the hands and the feet, and then this purplish rash would come across, and dry mouth, dry feet, cracking skin on the palms of their hands, and just sort of a sloughing of some of the skin. And so a lot of these symptoms where in the beginning, it was an old elderly patient, and then we started seeing younger, and then now we're starting to see people in their 20s, and now it's even showing up in even children. We need to be on the lookout for, recognize these symptoms early, and make sure that we're getting them appropriate care.
Okay, and we thank you for that, and we have got to get ready to sign off. Before we do, 30 seconds from everyone. Either tell us a good news story or a lesson learned in 30 seconds. Starting with you, Dr. Bullock.
My lesson learned is to slow down and make sure every patient gets a chance to talk to a relative before I admit them, regardless of how they look. Just slow down, make them get on the phone and talk to a relative.
Okay. Dr. Flana.
Wear your mask, wash your hands, and avoid groups, because you hear so many people that after they got it and they're sick in the intensive care unit, they wish they had followed the rules earlier.
Dr. Drayton.
Just mirror what Dr. Flanell has said, and also to have everybody, on the panel take care of yourselves, because the hours can be long and meals can be skipped and fast food grab, but you need to look after yourself so you can look after your family and your patients as well.
Dr. Wise.
I agree with everyone on what they said, but kind of switch it up. I think that laughter is good medicine. So tell a joke, and music, and sounds are good medicine. So play some music, so laugh and smile. And in order to heal your soul, you got to start with your heart. So tell stories and smile. I think we'll be on the right path.
And Dr. Adequate.
Two things. I am my patient's biggest advocate right now as a physician, and we need to take care of each other, and part of that is wearing a mask and staying home and socially distancing. So we just really need to take care of ourselves and each other.
Yeah. Well, I want to thank each one of you for your participation. Of course, great conversation, so much knowledge in this group, but even so much experience. And we're talking about real experience on the front line of taking care of these patients. And we will get together again and have another forum, because I know there are a lot more questions, a lot more things that we can talk about. But we thank you for participating. We thank you for the participants who stayed on all this time. I always get in trouble for going too long, but hopefully it was worth the extra few minutes. Again, this is Atlanta Medical Association. This is Ask a Black Doctor, where we want to answer questions that you have of people that look like you and have had your same life experiences. Please answer the poll that is coming up that Dr. Hubbard is sending out to you. And please do the survey. And again, send it out to everybody you can think of. We'll automatically get the results. And again, we thank you, and we'll be back in touch again soon. Thank you.